Hello, everyone. Welcome to the Resilient Aging Unfiltered podcast. Today we have a fantastic, amazing guest, Dr. David Weissman. Thank you for joining us, Dr. Weissman.
Well, thanks for having me.
Dr. Weisman got his MD from Penn State and then neurology residency at Yale, where he served as chief resident, and went on to University of California, San Diego for fellowship training, specifically in Alzheimer's disease and other dementias. He is a practicing neurologist and clinical trialist director at Abington Neurological Associates in Pennsylvania. He has devoted his research career towards advancing new therapies in Alzheimer's disease and clinical time to this population with memory and cognitive problems. Dr. Weisman founded the Clinical Trials Center at Abington, and as the site director, he's conducted numerous clinical trials in mild cognitive impairment, Alzheimer's disease, working with nearly every major sponsor, including to develop these new disease-modifying treatments, anti-amyloid therapies that were approved over the last 2 years by the FDA. And he's been published in numerous journals with respect to medical research and scientific papers. Thank you for joining us.
Well, thanks for having me.
What led you to want to work with this specific population with Alzheimer's and related diseases?
A couple things. First of all, thanks for the kind introduction. But the moment that somebody actually believes their own bio about how great they are, they are lost. They are lost. Okay, so most of it was about there's a devastating disease. Alzheimer's disease is fatal, and it really ravages our patients. We've seen that go. We've seen patients go from normal, where they have a little bit of memory loss, into more progressive, agitated states, real big burden on people. So I knew that Alzheimer's disease was fatal and terrible always. I also knew that the science had really evolved when I was coming up, as a med student and a resident, and there was nothing to be done for it. So, I had seen things happen in MS and I'd seen things happen in stroke that were novel and disease modifying therapies in those diseases that are also terrible, really bending the course of the disease. And I wanted to be part of that for Alzheimer's disease.
So it's not easy to work with older adults with cognitive decline because there are so many different things that are needed, and it's the care partner too. So just want to acknowledge that you've taken that on for your career. So you're one of the few people. So thank you for that.
I don't know. I mean, I think it's also hard dealing with anything in medicine, right? I mean, we're not in the business of making lips bigger, right? You know,
No.
I mean, not to trivialize
Yeah,
anything, but
no, I hear you.
we're not taking moles off. These are not simple things, and so yeah, okay. There's that kind of a doctor as well, and that's fine. Pediatrics, I think it's pretty tough talking a nervous, vaccine hesitant mother off a cliff, especially in this day and age. My friends who are like in radiology, they read a film, that's there forever. And their report is like they looked at that film for 5 minutes. You
Yeah,
know,
I see.
it's rough everywhere. But yeah, I mean, I think that this is kind of suits me pretty well clinically. The patients come in, they have memory concerns. It's a lot to come into a memory doctor for these concerns. A family is a little bit on edge, and just all that. I think it's a good fit for just who I am,
Hmm.
right?
Yeah.
So it's actually like a pleasure to deal with these families, especially in this new day and age.
Well, and so we're colleagues, and something that I appreciate about you and that I think fits in maybe here with why you feel like you're good with this population or in this work is because you are very direct and honest, open with your feelings and thoughts and opinions, and that helps destigmatize this disease when we're open about it and we talk about what's going on. And I can imagine you are very direct, like, hey, this is what, we did all the workup. So this is what's happening and let's find the solutions. Let's figure out what we're going to do here. And a lot of clinicians are afraid and dance around that. So maybe, I don't know if you agree with my assessment of why your personality might fit good here.
Yeah, I actually have a slide on this because the disease, Alzheimer's disease, it's underdiagnosed and underdisclosed and it's stigmatized. Again, when I was coming up, I did my internship in San Francisco in the year 2000. And at that time, HIV was highly stigmatized. So you would think about HIV as sort of end stage AIDS. Those were synonymous. And when we say Alzheimer's disease now, the idea of somebody who is in the later stages of Alzheimer's disease, totally confused, befuddled, wanting to get to a train station in a nursing home. That image comes to mind. And Alzheimer's disease is that. It's also someone who literally just gets mixed up trying to pick up their grandkids. It's mild and it starts mild and sort of goes toward that state that's pretty bad. But we have to destigmatize this disease, and we start by naming the disease, the earliest stage. This is what you do as well every day. This is myocardial impairment. This is Alzheimer's disease. We're going to name it, right? Like
Yeah.
Walter White said, say my name. You know it. You know my name. Say it.
Yes.
And actually, it's tough. It's tough to rip the Band-Aid off here.
Yeah.
Not every patient and not every dyad or triad, however many people are in the room, appreciate that for sure. And I had the patient reviews that reflect that. But if the patient wants to know what
Hmm.
this disease is, we are going to name it. And they are owed that. And we're going to name it as Alzheimer's disease. Or if I think that this is myocardial impairment due to amyloid, I feel like I owe it to them to say the disease. We don't beat around the bush with cancer. We don't beat around the bush with HIV. These are tough things to hear, that you have a cancer, you have another chronic disease, but we have to say it to move forward. And once you rip the Band-Aid off, actually, I find that that does a lot of good, because just a disclosure of the diagnosis helps spouses and loved ones figure out, my spouse isn't just lazy. They're not volitionally forgetting or not hearing me. This is a brain problem. And now I need to change my approach. I need to adapt to this person's brain problem.
Yeah. That's great. It's hard. Yeah. It takes a lot of courage to do that, but certainly I'm on the same page in that way. Maybe we could talk about your clinical trials work and how you've seen that evolve and what is exciting to you about that. Of course, there's been advances and that's exciting, but and then I'd love to hear your thoughts on what's not exciting or what's frustrating about the Alzheimer's therapeutic research clinical trials pipeline.
Well, trials are tough. I mean, to conduct clinical trials is really a lot of scrutiny, monitoring, a lot of adherence to protocols. I tell my study coordinators, if you do not want to screw up, just don't come to work, right? Because going to work and doing the work, you're going to mess up something,
Yeah.
because it's so difficult to conduct these clinical trials. We're dealing with humans, so humans don't always show up at the right time in the right place, and these trials are really complicated. But what got me interested in clinical trials was pushing forward from 0 to 1, going from nothing to something to bend the course of a disease. And in medicine, that takes a lot of work, preclinical work, and then a phase 1 dose finding study, a phase 2 safety and efficacy study, and then finally a phase 3 for efficacy, see if this stuff works. These take decade to a decades of time and thousands, tens of thousands of man hours. So it's just been a terrific ride. We enrolled our first patient, I did as a PI, in 8, with one of the very earliest monoclonal antibodies that was an anti-amyloid therapy. It didn't work out. And it didn't work out for that man. I mean, got into a trial that was destined for failure, even though the smartest people in the world thought it could work, right? But it didn't. Swallowing those losses has been its own lesson, right? I mean, disclosing to subjects who devoted themselves, and they either got a drug or placebo for a year and a half, sometimes up to 2.5 years, and then nothing,
Yeah.
right? It just did not work. Those are tough pills to swallow. But the field learned from those mistakes, thankfully, and finally have drugs on the market. And that's just been an amazingly awesome ride.
Of course, participants want the drug to work and help improve them specifically in their disease process, but they're contributing so much in every study. We learned so much, and those people that went through that in 2008 have directly contributed to these advances we have now. What do you say to patients and families who just say, like, I don't want to be a guinea pig in these trials? How do you encourage people to open their minds and hearts to them?
Well, each person is an N of one, and they have their own hesitancy about clinical trials. Currently, my focus is actually like, okay, you don't want to be a guinea pig. Good news, because people were trial subjects before you, and we now have these drugs that you can benefit from. You can benefit from them being randomized to either drug or not. And now we know. However, there might be some things coming down the pike that will be a clinical trial, and that could be appropriate for you. I wouldn't just bounce off the idea of, "Oh, I don't wanna be a guinea pig, and I want you to shut up about that." Maybe appropriate, maybe that's where your head is, but, maybe not. So let's talk about that. What do you actually feel is, "I don't wanna do this because you're gonna treat me like a guinea pig." Well, at the end of a guinea pig experiment, you probably euthanize and dissect the guinea pig. Well, we don't do that for humans. If there's a reason why you think that this trial is not a good fit for you, that's okay. We're certainly not going to coerce you or force you in any way. But I remember, one case, because we've done stroke trials as well. I had a patient who had a massive stroke, like an hour before. I mean, he's really in the golden window. Eye
No.
deviation, hemiplegia, really the full Monty. He had an LVO, and the family said exactly that. "We don't want him to be a guinea pig." And they're sitting at the bedside. "We don't want this." I'm like, and the neurovascular doctor looked at me with like, "Good luck with this one," and left. And because she had to prepare the case to go do endovascular therapy. But the trial was for a neuroprotective agent. And so I sat down with the family and I said, what Dr. Cho is doing right now is preparing the cath lab to get the clot out of your husband, out of your father. Only 3 years ago, that was in trial. That was a trial. We don't know, right? But that's why we do the trial. 3 years ago, we've gone from not having anything to offer a patient in that state, really bad stroke, to being able to pull the clot out, restore blood flow, the nerve cells survive. It's patients walk out of the hospital, and we're going to do that again, if you compare 3 years ago. So just don't bounce off this idea of joining a clinical trial, because if you came in 4 years ago, that's all we'd be talking about. If you bounce off that, this gives you an opportunity, not a guarantee. It's important they get all the information before they consent. But I actually think that if people say, "I don't want to be a guinea pig," they're also kind of resistant to the information. And it's really important that people get the information in order to say no, right? We think of informed consent as a discussion to get consent, but it should also be a discussion to get non-consent, to say no
Yes,
to these things.
absolutely. Yeah.
Yeah.
So I like that's such an important point to go much farther than scratching the surface and at least opening up that conversation because there's just a lot of fear there. And I'm sure a lot of people don't, go much farther because that person is defensive.
Yeah, they're reading the room emotionally, but they're not putting it into the right context. Of course, they're afraid of a clinical trial. I mean, all this stuff is happening right now, and they're coming at you with needles and hospital stuff. But let's just take a moment, take a breath, and create a space to really discuss these matters. Like, discuss them like adults and, we'll muddle through.
Yeah. and leaving that option open, or whatever the option, multiple options. And if they, after that conversation, decide they still don't want it, then that's fine. But in we also, as clinicians and researchers, don't necessarily always communicate well with patients and families in those moments either. So you're bringing up lots of important points about how things could be better. I'm
I've had
wondering
my
if
failures too. I've had my screw
oh, yeah,
ups, and
of
sure,
course.
I mean, like, my style and maybe the way say it, intend it, doesn't come across the right way. We've also had, bad things too. It's not perfect every day,
No,
for sure.
that's real life. That's when you're willing to get into the messy stuff, it's not always going to go smoothly. So I'm wondering if you're willing to speak to any things that criticisms you have of the Alzheimer's drug development, if things could be better in certain ways that you feel like would support more and greater and robust advances.
Well, historically speaking, we're still dealing with stigma of the disease. It was said we couldn't bend the course of the disease like Alzheimer's disease by focusing on amyloid. Well, those critics have been silenced because they were criticizing it year by year and with every failure while ignoring the advances that we did make, until we showed that we can bend the course of the disease. I guess the criticism is that we're not able to bend it to flatten the slope. We're still going to have progression. Some people don't seem like they progress much, but in aggregate, people still progress. So there's still more work to be. I don't see that as more of as a criticism. I see that more as there's still work to be done, and we still have stuff on the table that we need to do. In terms of overall criticism of the drug development, full stop, we have a really tightly regulated industry here. Um, there are many good actors, many people who are really put their heart and soul in it. When you talk to people who are in drug development on the pharma side and even the finance side, why are you doing this? And a lot of times it comes down to really a personal experience with Alzheimer's disease. So I think there are so many people with like their hearts in the right place. They're doing these trials for the right reason. It's just that the biology is really hard and it's a hard nut to crack. And it's taken many years to just even see the disease with amyloid tracers. So we're able to like now see the disease, biomarkers for CSF and blood to be able to measure the disease and then lower the amyloid. It's just taken so long to be able to do all of that that's why we're lagging behind in terms of therapies relative to other disease states. Another reason is funding. Um, there are many cancers, but there are about 5,000 drugs in development in oncology, right? So you get 5,000 drugs, and every once in a while you'll get a Keytruda. You'll get a drug that is absolutely magic and melts away tumors. And
Mhm.
kudos to Merck. But we don't have 5,000 drugs in development in Alzheimer's disease. We have about 100, and
Right.
plenty of those are symptomatics. So that's kind of my criticism, is that we don't have enough shots on goal here. Alzheimer's disease is what people in the industry call druggable. There are many druggable targets. So amyloid itself is an abnormal protein. It's not supposed to be there. Let's get rid of it, prevent it from forming. Amyloid produces tau spread. Let's block tau. Let's prevent it from spreading in the brain. And let's protect neurons and get better symptomatics. And so it's druggable, but we're just not doing enough trials. But then there are a lot of trial sites that you can't do all the trials, right? We literally cannot do every trial with a lot of merit that comes down the pike.
Mm, got it. So we s- there's been advances, but there still is a pretty loud group of naysayers, who are, a lot of them, well established clinicians and physicians and scientists and researchers that may or may not be in this specific Alzheimer's space. How do you respond to them?
Well, I think there's a spectrum of naysayers. I think there are reasonable people who just disagree, right? There are people who say these drugs work, but the clinical meaningfulness may not be optimal for patients. And to them, I say, okay, you know what? I think it's a nirvana fallacy. Personally, like perfection is the enemy of good. You're looking for perfect. These drugs are good. You can engage with people like that, and I think you can have a good conversation. Unfortunately, they're almost like the anti-vax contingent here, like conspiracy theorists of the amyloid cabal, the anti-amyloid therapies, were just tried and tried and tried until they finally, by random chance, had a positive trial. I mean, that's just lunacy. And that's really difficult to address. You see that those people are really kind of outside the field. Many of them don't see patients. They're not clinicians. They have alternative hypotheses, which is good as far as that goes. But great, you have an alternative hypothesis for Alzheimer's disease. Pursue it, get funding. I'm all for that. I will do your trial if I have enough bandwidth. But why stomp on the amyloid pathway that's borne fruit? So I think that that's unfortunate.
Okay. Thank you for sharing that.
And this is tough because it comes into patient conversations.
Definitely.
I have not had a lot of patients from around me, thankfully, read any of this stuff. But every once in a while, someone would be like, wait, the amyloid hypothesis, I heard that that's like kind of not real.
Yeah.
Like, where'd you hear that from? And they don't know, of course. They just heard it like on Facebook or something. I mean, they don't know. It's no deeper than just a bad feeling, but it does impede care. It prevents people from getting help, and it kind of further stigmatizes the disease. I'd also say that there are the fear mongers people who take the cases of ARIA because the drugs as a class causes brain swelling. It's called ARIA, amyloid related imaging, for people who don't know. It's a concern. It's a legitimate concern. We monitor for it. And they blow that concern up into this is really bad stuff. And I've seen a lot of ARIA, and I've seen people who are symptomatic from ARIA, which happens, and then they typically recover and get a lot better. And then we resume dosing, kind of like nothing happened. Meanwhile, people die of Alzheimer's disease. Everyone dies of Alzheimer's disease. All my patients with Alzheimer's disease historically have died of their disease or another cause along the way. So, it's a pretty bad disease. ARIA isn't bad. And that discussion is a personal one based on the patient and the family's risk tolerance and my own sort of like, I don't want to do harm, obviously. Rule number one in medicine, don't do harm. So if the risk is acceptable, then we can move forward where the potential benefit is greater than the risk. And maybe the patient will have symptomatic ARIA. But to put that first and foremost as like, nobody should get these drugs is so paternalistic. It's awful. It just can't, again, I can't dignify those people with a real good response because I just think that they're so off base. And again, luckily they're not seeing Alzheimer patients. So they may not even know the gravity of the disease.
Yeah. That was really clear and helpful the way you explained that. It does seem like some of those people do impact, though, primary care providers' views, and that then impacts their patients.
Yeah, I mean, while you and I are seeing patients, they're like writing blog posts
Yeah.
and like almost like commercials for their weird way of thinking. Again, it does resonate with some people, but the best people that resonate with my doctors who send me their patients are my patients, right? Like I was just on the phone yesterday with a primary care doctor who is sending me a patient. He wants to get them in quickly. And I said, oh, yeah, yeah. right, you sent me somebody else. And he's like, you know what? You know, I did send you. I'm just going to say Miss Smith. And I just saw her and she's doing great. I can't believe it. And it's been 2 years on lecanemab. I'm like, yeah. So that's the advertisement that matters. Miss Smith coming back to him with like, hey, doctor, my blood pressure, I think it needs to be adjusted. And he's like, wait, you're 2 years into Alzheimer's disease. Why are you, how?
Yeah. So you've prescribed these newish medications, these anti-amyloid therapies for more patients than most people in the world, I would imagine. And so I'm curious of are you accruing stories like that you just shared of
Yeah.
people hanging in there and maintaining?
Yeah. So we're about to pass about 200 people with anti-amyloid therapies, lecanemab and donanemab. We started dosing in February of 2023. And our first patients had suffered because there was a non-coverage decision by Medicare. And a lot of people were wanting to get treatment, but they couldn't because payers were not paying. And again, it was really a bad time due to the stigma of the disease. For the first time ever, we had an approved drug, FDA approved drug with an accelerated approval that Medicare did not pay for. And it was awful. You know, when you're seeing people progress through
Mm,
mild stages, now we know that people, even in the kind of later mild into moderate stages, just don't do as well. So the first people we got, time is brain, and they had time elapse on them, unfortunately, and they did not do so well. Although there were some great exceptions. I have a visual variant of the disease, and I'm sure you've seen these people just get worse and worse and worse. You know, her mini mental is like 25 now out of 30, can't draw the figures, can barely do math, but she's doing extremely well with language and memory, doing really amazingly. So yes, we're accruing success stories, and I wish I could predict what a success story looked like prospectively. I can't really, can't, no guarantees. But yeah, I have a lot of experience with the anti-amyloid therapies. I don't think I'm the like number one prescriber out there. I think that there are some institutions that have really stepped up and are prescribing way more than me. So if I'm going to cross the 200 threshold at some time, I think this year, but maybe early next year, I happen to know that Penn is about 300 right down the street from me. Washington University, I think, is well over 400 people.
mm, okay, so you're in the top 5.
And in the top 5%.
Yeah. Okay. Okay. Sure. Um, well, that's so eventually the proof will be there. People, as time's going by, the naysayers can't. What are they going to say against this hundreds of people that are
They'll
motivated?
always be there. They'll always be there.
Well, fair enough.
You may not be aware, there's an underbelly of stroke care. So TPA for stroke, I mentioned it before, but it's very similar. The analogy is really there. A novel medication that is somewhat dangerous, but given on label can do great things for stroke. Well, it's really tough when you're an ER doctor in rural Nebraska to give TPA. Kudos to anyone who does, an ER doctor. But there are many doctors who are sort of biased against TPA. And so there's this whole subculture or sub medical culture of like finding little ways that TPAs, yeah, they have their own like journal clubs and their own like echo chamber. The same thing is going to happen here. I mean, there will be the anti-vax community, there's the anti-TPA community. There are going to be those people just until they come up with something that you can sort of argue with. Again, it's hard to dignify them at this point.
Okay. Well, good to know.
Well, the gossip, right? About some of them got into big trouble.
No, I didn't hear that.
Well, I'm not going to name names, but A New York Times reporter was sort of snooping around for bad problems with the anti-amyloid drugs. So a couple of authors had a paper where they kind of did the same anti-vax play. Again, it's very analogous, right? The anti-vax people will look at unsubstantiated reports in something called VARS, the Vaccine Adverse Event Reporting System. Well, there's something for medicine called FARS. So the anti-vax look at VARS, and they saw that people report they got the measles shot, and then they have a fever. The kid has fever, and maybe even has a febrile seizure. They, the anti-vax people, will take these cases and say that vaccines are dangerous. These people, and again, like some of them are Alzheimer's people, they looked at the reporting forms and they tried to do incidence reporting. That was the paper. It got denied. But they had told the New York Times that these drugs were dangerous. The New York Times is like, where's the data that these drugs are dangerous? Because it wasn't shown in the phase 3 trial. So then they put a preprint up on the
Mm.
internet. So that gave them enough deniability. But unfortunately, the preprint was an early preprint. And then things got heated between the people because some of those co-authors are like, whoa, 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 I never signed off on this pre.
Yeah.
And
I did.
so
Yeah,
it was delightful because, contrarians are contrary even to themselves.
it's true. I did know about that. I thought you were talking about something with TPA, with the TPA, anti-TPAers.
Well, I
So,
can't say that they've ever done something like that. I mean, who even knows, right? I mean, but they're still out there.
yeah. I'd love to shift to talk about the Alzheimer's Quality Initiative, which you recently started. Can you share what your vision is for that?
Yeah, so, we're all plowing along doing our own thing in practice or in academic institution. And I talk to my buddies, I call you up, I see you around and we share some cases here and there. But there's not a lot of opportunity for community. So the one thing I wanted to do is I wanted to create a community of doctors who are treating people and not like-minded. I don't want everyone on the same exact wavelength. Different people in different areas of the country are going to have different opinions, but I want people who are treating Alzheimer's disease seriously and treating with the anti-amyloid therapies to coalesce. And once that happens, I feel like we will attract more quality people to coalesce with us and be able to talk about difficult cases, perhaps put together some projects and be like a light on the hill for other people to get treated. Because if you think about like the impact that I can have or you can have with a patient, that's good. But these drugs, my sense is that they're being underutilized and people are slipping through and they're not getting caught early enough and they're not going from memory loss to I'm getting an anti-amyloid drug in my arm fast enough. Time is brain. So if we can speed up that time, if we can get some quality initiatives around all of Alzheimer care, I think we could really make a good impact, not just on the patient in front of me, in front of you, but maybe on the entire system. So that was sort of the impetus for all of that.
I really love what you're doing. And I've often thought about how odd it is that there aren't groups of physicians just coming together who are actually treating patients, and that group being more the drivers of um, clinical practice guidelines in the US, for example. So to me, and I'm in the same field as you, and sometimes it feels like there's a researcher in Europe who's telling me how to practice medicine in the US healthcare system. And there's a disconnect. And also just the real world use of medications is very different than how things go in research or can be. usually is. So I really appreciate what you're doing. And I guess also sometimes I wonder about neurologists being willing to speak up and take the initiative to have a pun there. So I, want to just acknowledge you for doing this. And I'm excited to see what comes of it. It's so important.
Yeah, it's cool. You get to talk to people who are around the world. I mean, we have sites in Australia now. Yeah, so it's really good to be able to talk with and collaborate with people. So yeah, more on that front later. The people involved with this so far are awesome. You're one of them. So
Yay.
they're all great. Yeah, it's just a terrific thing. I totally agree with you about the seemingly disconnect because I get it. Having been involved with some guideline formation and recommendations, it's really difficult to write a guideline and then apply it to a patient who may defy the guideline. For instance, the current guidelines say nobody with anticoagulation should
Yeah.
be on the medications, right?
Right.
And yet they were studied. And yet some patients cannot get off anticoagulation. Again, putting into context that their disease is fatal. Would you really take that drug off the table? Now, consequences can happen from these drugs being given with anticoagulation, for sure. And I don't want to minimize them. But that decision should not come from a committee. That should be a decision between a doctor and a patient and a supporting family. But we should all be on the same page. Um, I have offered it to people and, they didn't take me up on it. So after we properly discuss the risks and benefits, and actually, I think this is very much in keeping with my discussion about informed consent because they have to have the information to make the decision. And when we're talking about degrees of risk as opposed to an absolute contraindication, it's a different story. If you're allergic to a drug and it will cause anaphylaxis, you cannot get that drug. Okay, that's a contraindication. Where the known harms are known to be worse than the benefits. The benefits are less than the known harms. In these situations, it's not known prospectively. Moving forward, we can figure it out and hope for the best. So I find them a little bit too heavy handed. The other thing is that these are new, right? So it's almost like we need to, some of these a little off label things to push the boundaries a bit, right? So in
Mm,
some countries, there are ApoE44 people, which is a gene that puts people at extremely high risk of amyloid forming in the brain. Therefore, they're at high risk of Alzheimer's disease. But they're also at risk of the side effect that I mentioned, brain swelling or the ARIA. They have increased risks of that. So there are countries that have disallowed people who are ApoE44. So in addition to mandating genetic testing, which is, a little bit of a weird thing for a state to do, they're disallowing a drug based on genetics, based on risk. And so, I think Americans need to kind of show the way that we can dose people who are ApoE44 and keep them out of harm's way.
yeah. I'm, totally on the same page as you. And that was very beautifully stated. And I think about that feels paternalistic to me to not even allow people to be considered who are ApoE44 if they have no other clear risk factors for ARIA, especially, and to have that conversation and to make the informed decision for themselves. Maybe my one more question. So, if you could give one message to a fellow neurologist or primary care provider about what's possible today in Alzheimer's care, what would it be?
Well, first of all, nihilism is no longer an acceptable mode of thought. It's a toxic, always was a toxic and horrible, diseased thinking about a disease. So we should get away from therapeutic nihilism. If we can name the disease early and catch it early, we can bend the course of the disease and prevent some of the ravages from happening.
So maybe I could paraphrase that. There's rather than saying like there's nothing we can do, so why bother? There's actually so much we can do now, and especially with these new treatments and more things on the horizon, thanks to hard work like you and others.
Yeah, I mean, clinical trials are still ongoing too. So even though there's an unmet need, if you're kind of skeptical, well, then get to work, right? One thing I don't see the skeptics doing is actually rolling up their sleeves and
Yeah.
conducting clinical trials
Yeah.
in their alternative hypothesis. And I get that that's really hard. Getting funding and implementing clinical trials is one of the hardest things ever. It's basically like building a boat from scratch, right? Each trial is so difficult to conduct and complete. But I mean, I just don't see them doing much other than critiquing. And it would be different if they're engaged in a solution, not just tearing down the current solution, but their own solutions. So anyway, but I don't want to end on that note. I want to end on the fact that we have therapies now to bend the disease. So it's kind of like a pinch myself, like patient comes in and they're early and they're appropriate. We can take care of you. We have something to offer you. Unlike, again, just even 3 years ago. I mean, it's completely different. So that's awesome. We now have symptomatic drugs that really work, like this medication, brexpiprazole for agitation, has been a godsend as far as I'm concerned. It's an amazing medication when it works, and it usually does. So I've really had good success with that as the data bears out. So that's been terrific. And then the future is bright. We're going to be able to bend the course of this disease even further and change it really into hopefully a nuisance and not really a deadly disease.
Yeah. Love that. So where can people find you that want to get your clinical care, get into these treatments and research?
My life is very boring. I live right north of Philadelphia. Go Birds. So I'm in Philadelphia. Northern suburbs of Philadelphia. Abington. It's a beautiful area.
Thank you so much for your time and everything you're doing to advance this field and help patients and families who are facing these diseases to give them hope and possibility.
Yeah, well, thank you. You're doing the same thing. I feel like that's
Yeah. Cheers. All right. Well, thank you, listeners, once again. Thank you, Dr. Weisman. Pleasure as always. If you're watching on YouTube, please like and subscribe. If you're listening on the podcast platforms, please rate and review us. Feel free to send me a message anytime, Dr. Cabral, Dr. Cabral at mybrainlove.com, or check out our website for brainlove at mybrainlove.com. All right, we'll catch you next time, everybody.